Hi everyone, Anaganja Narawa Apple, Kirija Nara of the Gringai-Wonnarua Nation. So, and I want to acknowledge the Turrbal, the Yagara people of the Turrbal Nation, whose lands, winds and water are all on now, and we benefit and share, and we are here because of the care of the land and the spirit of this land that's here. I want to acknowledge all elders, past and present, but I want to acknowledge non-Indigenous elders here, and I think there's so many men and women here and up-and-coming elders who, and in my definition, an elder is a person who has knowledge and culture and passes that on, and we have Aboriginal and non-Aboriginal elders here in this room, and I just want to acknowledge you all. And I want to thank the ANPA for letting me come. I've got a few admissions. I was really late getting the force. I was on the dark side for a long while, so I was well over a couple of decades in the hospital system, and so but I learnt my lesson, and I came over to the Luke Skywalker side, and so I was a bit of a late bloomer in primary health, and I'm not talking about my weight only, just for the rest, but I was a late bloomer, and I held very poor attitudes. I was silo driven, you know. We in renal and cardiology and diabetes, we know it all. I was one of those stupid people, but I'm in the light now. So I got fed up with doctors doing the wrong thing. I got sick of being dragged in 4 or 5 times a week to do acute dialysis or apheresis, and I'd be sitting there thinking, if only that doctor had reduced those blood pressure medications, if only that person had been put on a fluid tablet, if only that metformin had been stopped at a proper time, they wouldn't be in metabolic acidosis, if only. And so I was lucky enough to start my role as a NARC probably 5 or 10 years before we got the nurse practitioner movement going. So I've been a nurse practitioner now, this is my 16th year. And so I'm trying to use my skill set now for good, not evil, in the primary health sector, because I realised that in the hospital, they're Band-Aids. You're just a Band-Aid. It's too late. You know, they're in end-stage renal disease, they're in end-stage this. You're just a Band-Aid. You're better off being somewhere where you can do preventative work. And I was so naive to think, oh, I'll just screen for a HbA1c and an ACR and I will fix that renal disease just like that, until I got snotty-nosed kids after snotty-nosed kids covered in scabies and crusted scabies and impetigo and tonsils with pus all over them, that I realised, and pregnant women who will drink a goon of Moselle and be covered in sores, and I realised that there's no clear line, that you have to just deal with everything that comes in, but everything we get in primary health is fixable, everyone. And now I look upon it that I charge you all that if a person progresses to renal failure and you don't find them till stage 3, it's our fault as nurses. Did you do that dipstick on that health check? Did you simply do a small test? Because I can tell you the doctors are not going to dip a dune stick. They're not going to do a blood glucose. God forbid they would do a blood pressure before they went in the room. And I'm talking about a manual one. We've just got this wonderful position where we can stop everything if we just think of it as not being just mundane, but think about doing a urinalysis is the window to the world. The window to so many issues, liver, kidney, heart, everything, infections, everything. It's so important, yet we see it as mundane. But we in primary health don't see that as mundane, because that's our stuff we do all the time. And I realise now that this is the most important place to be if we're going to prevent diseases from progressing ever. It lays with us out in primary health. So I've been given a job that's already been covered. Robbie's already done it, but I want to lay a bit to you, because I think there's a lot more we can do in identifying what we do. And so I think I want to articulate what sits underneath what Robbie has done. And he's given you a lot of options at the end, but I want to articulate underneath that. And if I could say one more thing, I want you to do this. We all hear the new word multidisciplinary. Do you all think that's a great word? That's shit. That is the most shitful thing I've ever heard. They're in for 2 minutes with a button and the script flies out and you're with them, you're listening to all this and you're listening to the troubles at home and you know this is happening and this person's stressed and I better get them booked in because they don't look well, and you've listened to all this and he flicks out a script and they bring the script in and they go, what's this? You explain it, you look at it, you go, listen, give me a ring next week, I'll see if you've got any side effects, we'll do this. We take that little tool that they spit out and we cure people. We're the ones who do the work. We're the ones who worry, follow up, recall, do the bloods, look at the results, shove it under their nose, quick, quick, look at this, potassium's 2. We're the ones who do the curing. Now they've all figured out, crikey, we better call it multidisciplinary so they can ride on the nurse's coattails. But it's true. Tell me it's not true. Tell me who cures people. It's no one else. And pretty soon we'll be nurses. We'll be able to prescribe. I think that's marvellous in so many ways. We've got to do it right. We can't be tripped up and be shame in front of people. We've got to do it right. But there's so many things you will do better. And we will keep up to date because we're under a microscope like nurse practitioners. We only do evidence-based. I'm tired of seeing 80-year-old physicians still using mini press as a first-line management, and they fall over and you come in and you figure it out. You figure out the drug interaction. They'll tell you how many home remedies they're on, but they won't tell him. So we cure, it's us. But anyway, I want to, at the moment, I'm coming from tertiary referral where I did acute dialysis, apheresis, all that sort of stuff, transplantation, nurse practitioner, looked after community dialysis for 8 years, and the rest of the time now I've been out in primary health. And so I'm part of a wonderful process of starting up a primary health service in Dulmingi in far north Queensland in the lower Gulf, where life expectancy is 55. They've had a hospital there and they've had it there for decades, and life expectancy is still 55. So guess who they've called? Primary health nurses to go up and fix it. And I think that'll be marvellous. So we all know there are issues with delivering health promotion, and it's not as easy as you think. And I am so tired of hyperbolic messages coming out. Although they're trying to change it now, the hyperbolic messages deafen a lot of our patients. Oh, if you are fat, you are going to die. Oh, if you eat this, you will get high cholesterol and die. Oh, if you don't keep your blood sugars, oh, you will die. Oh, you will get your feet cut off. They're hyperbolic. Most people, especially low socioeconomic people, Aboriginal people, and I've worked in just housing commission areas where there are only 30% Aboriginal, but they live in now. And you've got to think about your target audience. They live now. To save money is future orientated. No, it's what makes me feel good now. What do I eat now? What do I drink now? What do I watch now? To send your children to school and get an education, that is future orientated. It's not a priority. Looking after your health, future orientated. It's not a now. So when you're thinking about your audience, those who work in very low socioeconomic, remember it's now. It's what makes you feel good now. And that's a really important thing to understand, that people who are not future orientated, and with Aboriginal cultures we live in a circular, my nan was from a mission, it's circular. We live in the past and the present. And the past was our richness and our dignity, and the present is not. And so we make ourselves feel good for now. And you weren't allowed to dream of the future. And remember, I'm 57. I was not counted as Australian until I was 7 years old. I was counted as flora and fauna because I was part Aboriginal. We pretend to be Spanish because I could have been taken. 2 boys were taken for my class, the lighter you were. My nan is absolutely black and Aboriginal. And so it's a very new wound, living in the past and not being able to speak your language, not being able to practice culture, practice your medicine and do things. So remember, a lot of people live in now, and so health promotion for that is rewards. It's now, whereas people who, the more education you have, very much on you take a message for future orientated. You'll prepare for super and do all that. So it's a huge issue. So hyperbolic messages to people who live in now, get away from it and stop saying, if you don't take this, it's a hyperbolic message. It's useless. The language use, there's still a high rate. People come out and they'll talk, and a lot of communities use Aboriginal English. They're losing their own, but they still speak Aboriginal English, where often a verb is put in front of a noun. Running, im running, or now, what now? Now, like, and then they come in and go, now you take your insulin and you're going to draw it up to 16 mils on here. You take it and you pinch a bit of here and you put it in there, and they go, what him saying? What him saying? And so we're not targeting. It's great if it can be in language, but most don't even read their own English, let alone read their own language. And so messages have to be very simple. And Robbie is making this excellent start where he just speaks. But even in the way you speak to many communities, we get all these wonderful people that are coming in like they're the right hand of God, the specialists, going, oh, you've got cardiac failure and you're not taking your medications. And they've got 6 people staring at them, and they're intimidated, and they don't understand a word when you only speak Aboriginal English. And it's still English, and they assume because they're speaking English that they'll understand. But there's no hope in hell that they'll understand that. And so language is important. The medium that you use, we have very poor social media. Nobody can afford them. There's very few phones, and if they are, they're simple ones, and it changes when the kids smash that one, they have to get another one. So the medium use is often important. And quite often, and this is from some of the patients, they go, God, they just keep stuffing that down our neck. And so it's important that you don't overkill your message, because then it becomes on the negative side. And often people come in and they're taking the moral high ground. I know best for you. Well, you would have been a really great white master in the days of the missions. I know best for you. People make decisions with what they can live with, and so you don't know better than everyone. And that person may be very happy to die at 50. That has been always the way. They may have made that decision. It's not for us to say, it's for us to inform and leave the decision to the person. And this constant practice subservient tone that people do, look, I'm only doing this for you. I'm going to get the medications for you. I'm going to do this for you. Well, that's a practice subservient tone that is meant to guilt you into doing something. And people see that. They feel it, see it, and know it's intimidating. So these are some of the issues which I've watched a lot of people come in with. And this, I think, is really important, that they're the architects of their own future. You just take them in as is. If they've been informed and know and they've chosen the things they can live with, then that's it. You do what you're allowed to work with. But they're the architects. Don't stuff it down their throat, because it doesn't make them any hungrier for the message you're giving them by stuffing it down their throat. And many threats have been around for so long that messages have lost their force. Oh, you don't take these diabetic tablets, your leg will go. Well, they've heard it so much. 50,000 people say it. Change it. I'm not worried if you lose your foot, you keep me gainfully employed. You'll be back in here, great. Let me know when that foot's sore. I can get you a pair of shoes, might help. Work with what you got, but don't stuff it down their throats, because they won't make them any hungrier to do the right thing. You can only do your best. And we also, I think this was important. I read Barack Obama that he says we live in a culture that discourages empathy. So, oh God, she never takes her tablets. God, she hasn't even bathed for 3 days. So we just like, God, they don't do what I say. All of a sudden my empathy's gone. You have to look at it differently. People are allowed. You're allowed not to take your tablet. I'm allowed to be fat. I'm allowed to be this. I have chosen what I'm going to be. I'm the only one who has to wear those consequences. Empathy belongs to everyone, whether they do what you say or not. And that's important. And paternalism is not always balanced with self-determination. We're very paternalistic, especially all the specialists that fly in once every 2 months and think they know everything about communities that I've been working in for the last 8 years. And I've worked in a lot of different communities and set up clinics. And they walk in, and it's about paternalism, not about helping that person to be the better person that they can. whether they take up the treatment or not. It becomes, so these are a lot of the issues anyway. And so how do we do it as nurses better? And I agree with Robbie. I could have done medicine. We could have all gone on to do other things. I've loved this. I love our philosophy. I love our approach. I love the way we can see this person and the person sitting next to him and how tired they are. I love it. I love not having to do a 6-minute consult. And I think we can do it better. And so I just want to talk a bit about health promotion and how to undertake it in primary health. And I want to inspire you to do a bottom-up approach. So we're not going to do this paternalistic, hyperbolic thing that rams things down their throat. I know we're already doing bottom-up stuff, and so many of us do it. But I just want to look at a couple of approaches that you could probably use to help. Of course, the agenda, I'm just going to touch on what it is, elements of health promotion, things to consider, and how to undertake it in your own practice. And so we all know where health promotion came, and that's the Ottawa Charter definition of what health promotion is. It's enabling people to increase control over the determinants of health and thereby improve their health. So looking at the determinants, and so that not is only medicine or doing this, but also the social and environmental issues. It's evolved hugely worldwide, and we all know that because health promotion is a massive issue. And you're trying to skill up that person, not lecture them, not be paternalistic. You're trying to skill up this person. So it's a different way of looking at how you help people with illness without being paternalistic or over the top. When you're looking at health promotion, there's many programs that you can look at, and so I'm just going to touch briefly on some of these things. Programs mean that there is planned, organised and structured activities or events that focus on helping a priority target population or individuals within your own area to make informed decisions about their health. And for us, that includes things like cultural alternatives, not only the alternative you want, but other ways. It can be promote policy, so it can be very high level policy, environmental, regulatory, offering immunisations at a high level across Australia through big government organisations, and it plans for change in health promotion can be applied to individuals in various settings. But this is sort of the elements of it. So you're looking at what type of thing you want to change about the people in your practice or Australia-wide, who should be taking it on, and how you then develop. So there's some elements around what you take on. I think this is where we sit. So we are the bottom up. We are the counselling, health education, clinical consultants towards the individuals and community development and empowerment. Advertising, you'll do sexual health screening and then offering treatments. So it's a health promotion out through advertisement from a bottom-up level and getting in. That is a great example. So you're looking at the illness or the health risk that you're targeting within your area, and it'll be different from the North Shore of Sydney to Doomadgee in the lower Gulf of Queensland. So you've got to look at your own stuff, and then what are the contributing factors to it all, and then looking at the behavioural applications and the environmental things that you can influence within your area, and then hopefully improving quality of life. So there's lots of theories, and my eyes glazed over when I got to this part, and I thought, oh, here we go. But when I started to read a few, I thought, I'll give you a few examples because theories do help you. They give you a roadmap. They explain the dynamics of what causes this issue, so what you can be looking for in your area. You get to identify targets and what you can do about it. It guides reasons for why people do or not engage. So looking at all the different theories, and you need to look them up, there's quite a few, but they actually help you to figure something out, plan it, get it in, audit it, and understand whether it's actually working and get people engaged with what you're doing. And so here's one theoretical model that you can look. Do you want to target public policy? Do you want to actually, as the APNA, target an issue we all identify and target vaccines to be put into worldwide? So some programs target at that very high level, that intersectional model, but I think we're looking at individuals with their knowledge, attitudes and skills. So we're looking at that bottom up, we're looking at the central part of that theoretical model. Here's another theoretical model that, and I think you've all seen that. So that's another model that you then work and you have plans for each different stage to help somebody change. Here's one more model. And so and that's sort of the other one, similarly, but here's some actions that you can do. So pre-contemplation, your health promotion might simply want to target pre-contemplation. That you may just want to do that. And so advertising is pre-contemplation. The whole health promotion thing of advertising is just simply targeting pre-contemplation, but having an action for the bottom. And so you may want to just go straight to problem solving and social support. So the ad might be, would you like to be screened for pre-contemplation, but have you been sexually active? We offer treatments. So you can pick a layer of that in your health promotion to actually target one or all in what you're wanting to do with a patient. So it doesn't have to be that you take on the whole disease spectrum. You may just want to put ads out. So you're targeting just pre-contemplation for issues. Have your kids got sores? Pop in at 8 o'clock, we'll dress them before school. And so that's like a solution and a throwing out there to let them contemplate, oh shit, yes, I can't afford to start work again, or I've got something on. Geez, I can pop in there and they're going to do simple quick dressings to cover school sores so they're allowed to go to school. So you can target anything along that. And so it's about thinking about what are those levels you could do. See, so theoretical models aren't sort of too bad when you start looking at them. You need goals and you need objectives. And so when you've figured out what, you do need to have a goal and what you want to achieve out of it. And so it might be the school sores that you want to get, at least all the kids that you are getting attending school and not missing school because they can't. So looking at, have they been missing days because of those school sores and they're not allowed in the school? And now is there full attendance because they're going? So simple objectives on what you're looking at and trying to, ear checks for kids before they're doing their swimming. The swimming carnival's coming up. Offer school screening of ears, nose and throat. One school I did, out of 263 kids, we had 91 with otitis media, punctured eardrums and everything. So that was an advertising thing. We want this kids check before the swimming carnival, and found all those issues, and so we're able to get them treated. And what do you want to get out of it? So think about that. But when you're looking at all these to plan and implement, you're looking at, empowering. These are the things you want people to do. So you want to empower, and out of like the school sore things, now we have kids dropping past our clinic of an afternoon going, I got one of them sores my friend had. So we've empowered kids now to not only say, hey mum, I need a cover, or I'll just go over. We ring the mum, can we treat your kid? Yes, we can cover the school sores. So empowering even kids. What we have is, where in a lot of places I work, low socioeconomic, is an apathy. It's normal to be covered in sores and scabies and not have shoes and sores and cuts and things. And so we don't have a very good generation at the moment of health-seeking adults. And so my dad always said, if you want change, you start with kids and through the education. So doing things with kids is always good because you change their nature. I become a health seeker. And so the kids will drop in after school. Now I got one of them sores. Great. And you come in any time. Involve those concerned at all the stages. So ask the mums, what time do you need us to open? What time does your school start? How can we help? Ask the teachers, what sort of covers do you need to allow the kids to go to school? So things like that. You're going to ask, not assume that you know how that solution will still get those kids to school if that's your goal. when you're looking at the intersectional, so I want to work on scabies at the moment, so I give them all the cream, they put it on, they go home to the filthy linen, nothing works. So trying to save the children to buy 2 big industrial washing machines, because so many of the people where I am don't have washing machines. So trying to get industrial washing machines. Trying to get the wellness centre, the plan is to go and ask them, will they teach the mums to make Yarrabah bush soap or tea tree soap to wash, so the kids can wash. And there are showers that save the kids, so they can have showers if they're not can't have a shower at home. So it's about that, you know, if I'm going to do the school source and they say, yes, we want you to do it, and you can, you know, as a nurse practitioner, I can bill an item. Well, should I move to the school so I can see a lot of them as they're coming in, and I do an hour every morning. So discussing with the school what's the best option to tackle all the kids, and that way you might get more kids in there that they're not going to send home, they're going to send to you and then back into the classroom. So that intersectional, and you've got to be guided by a concern for equity and social justice. So you're not excluding people in office for things. You might be even putting it out there that you do SOARs for people who've got to go to work. On the few that, you know, there's limited employment and they don't like missing work, but you shouldn't be turning up covered in SOARs either. So you've got to think about those sort of things, and sustainable. It's great that you might be able to do it for a week, but you know what it's like, you get slammed, you've got 35 people out there. Some days you get to work in the morning, there's 19 people in your waiting room, and so I can't come in, I can't do the SOARs today. So it's got to be something that you can maintain and negotiate like that. So just things to consider now coming up with your own, that a lot of funding set on some of the health promotion issues just doesn't pan out. And so try and look for barriers to what you're going to do, because you don't want to be spending money if you can get that lovely immunisation money, but that your plan didn't work and it didn't boost your numbers or something, you know. So think about that. And interventions can have very unanticipated and even untoward effects. So they slam posters all over Dormagee about STIs and screening. And one of the ladies said, what them? Everybody come in, they think we all got this. We all got this. So there's this assumption now that everybody in Dormagee has all got sexual health STIs, everyone. And yeah, we're picking up a lot in the young. We're not picking up greater numbers than you'd see normally, but everybody's tarnished now and think, oh, they've got them everywhere. They all think we all got it, you know. So there's harm out of some health promotion activities. You've unintentionally implied that whole place, and you know, the don't drink and the domestic violence, and they go, people coming through here, you know, they're coming on the Savannah Way and they all think, geez, we just bash our wives and we've all got disease, and and so it's harmful sometimes. And because there is no social media where an individual can choose what they want, sometimes there can be harm. And so we can't get health workers to help with STIs and that now, and things like that, because it's now such a shame that everybody thinks, God, if I'm working it, they'll think I got it, or then I'll know and they'll know. And so there's fallout with some things. And so you've got to be really careful about how you do it and what could be the perceived effects. I think this is really important, that you understand the relationship between people, and nurses do. We understand our people better because we talk to them. We understand the relationship, the environment, where they're coming from, their behaviour. We get to know a little bit more. And knowing about our setting, so being in your own suburb, your own city, your own placement, you can optimise success because you know the nuances that sit under it and why people come or don't come, and you can anticipate barriers. We anticipate them better from the bottom up as nurses. And I think we can get our goals and objectives achieved more because, and I think that money that's going to come out for that sponsorship is awesome, because this is that's funding for ground up health promotion and treatment and management options. And well-meaning interventions can have unintended effects. So because we've raised awareness on cardiac issues, now we've got cardiologists coming in, but the untoward effect is he and she come in and they go, oh, do you mind? I've got my registrar and my nurse here and we'll all be in the room. And they're asking the person who's already like embarrassingly humbled in front, given no choice. And what are you going to say? Somebody is already too shy, and to say, no, I don't want 4 other people shame job. Like quite often they'll say, I want to shut that door. I don't want anybody else to know what I'm going to tell you. So unintended effects is, what is your treatment? It's not going to be the solution coming in, and then it's very, very awkward. And then they're shut up, they're not listening because they feel awkward. So the health promotion campaign around picking up these incredible amount of heart failure and things in the community, and then the solution walks in and stuffs it up and they go, I'm not coming back. What they say, you know, that fella says, oh, I'm going to die if I don't, like, wrong. And it happens all the time. They all swan in. The dermatology team, all of them, they swan in, and they've got 55 people who think, fantastic, I'm going to Doomadgee for the day, I'm going to a real Aboriginal community. I'm going to learn, I'm going to see, ooh, pinwheel worms in the diabetic ulcer's foot. Ooh, I'm going to see it all. We better all pack into the room and see this person. Oh, he said it was okay. He didn't say it was okay. His body language said, I am dying here. And so also think, because if you're doing the dressings at school and the kids are going in their room, will they be really shamed by knowing they've all gone in there because of you? So you're swanning in with the same thing, but you're embarrassing and you're shaming all those kids, white or black. You know, you're just shaming them that they've got to go in to see you. So it's thinking about the unintended consequences of what you come up with. So that's part of that social justice view. So I think we've got to look at our own weaknesses. We can never say, yes, we think we're awesome, and I think we are. But also we've got to understand we have a lack of understanding about health promotion concepts. So that's why I wanted to shove the different programs and the theories up. Have a bit of a look. Pick a theory that suits what you're doing once you find what you're doing. And then really look at the social justice issues of it and the impact and the barriers and everything. And we've got limitations in training, and I think Robbie should have given this one, because I think he's bloody tackling a lot what I'm saying. And then now I want to get into what you're going to choose in your own practice. And it's not something that you feel you're an expert in. So you're not just going to roll the wheel, I'm really good at these things, and you'll spin the wheel and I'm going to pick that topic. That's not how it works. Within your practice you can ask. You can all get together and figure out who's going to decide the topic, who's going to address the issues, what you're going to do. So it's a great way to think about all those questions before you head into it. But to me, there are 2 sources that you should use, and this is coming back to us and our skills and our scope of practice, is our experience. And that is derived from our lived experience with our patients. And this is how, as a nurse practitioner, I've expanded my scope, is my lived experience. When the first 200 cases, when I worked at a Wobbecool, came in and they are all skin issues, I went, holy dooly, get me a course. Because I'd been dealing with infected catheters and sepsis and cellulitis and Charcot's and very end-stage stuff, but here was this stage stuff, so you need to upskill that. And so, so we have that knowledge, and the other way is a critical reflective knowledge, looking at your data, your social aspects of where you are and everything like that. And so what is your experience? What is the issue you're seeing comes in that really irks you, you're seeing a lot of? And so it might be that, and for me, it's these ENT issues, it's the homeless, targeting the homeless. That was one health promotion gig I did. I had the privilege of working at Coledale Community Health, and I was asked by Walhollow to start up a clinic there. That was the pinnacle of my career. It was all nurses, all nurses. It was me as a nurse practitioner, there was a wound nurse, an ENT nurse, a child health nurse, a chronic disease nurse. We had our own ISTAT doing UECs as well as HbA1cs, ACRs and everything else. Mental health nurses, please keep naming them. We had the building full of nurses. We turned one person away with a fortnight when we did our study, and that was because she was trying to have the baby here with us, but the maternity nurse didn't want to have it, and the next one was a heart attack, and it would be things like that. They would come to us for the help. And in the long run, Tamworth Hospital were even sending down things to us. Because between all of us and our scopes of practice and our time and our bulk billing, and in Tamworth, no one was bulk billing at that time. It was $170 to be seen if you had a chronic disease. It was $70 cash up front if you wanted a normal consultation. And this was an area of low socioeconomic people, 30% Aboriginal, 70% mixed race, but mainly white, Caucasian. And you could drive for half an hour and not come to the end of the Housing Commission. And so nobody was getting seen for anything. And it was all nurses. And in 12 months, we had 1,200 clients, regular clients, and we were screening every school. Power to nurses, it was just one of the most ultimate. Then the Aboriginal Service mission I was working for, who'd sent me across, it was about an hour and a half away, got a new practice manager who said, oh my God, all those GP MPs and 715s we could be signing off. God, we've got to get a doctor. And that was it. Oh, Les, we haven't got room for you now because nurse practitioners, really don't bring in that much money. You know, my 10 sutures will give me $17, not the 170, you know. Same work. We're sort of good enough to do the work but not ride the bus. We're back in the 50s, you know. We're just back in the damn bloody 50s where I'm good enough to diagnose you with diabetes and start you on all of your medication, diagnose you with heart failure and do all of that, and yet $17.50 for doing the whole damn thing. And my plan is worth nothing. One mission I did 200 health assessments and management plans, and then Medicare said, oh my God, this mission's never had a 715 done. No one's had any health checks or anything. All of them were being managed and diagnosed and beautifully managed, and yet invisible to Medicare. In a system that values data so much, the work we do as nurses and nurse practitioners, your item, does it say whether you're giving an iron infusion, a complex thing? Does it say whether you're cutting somebody's toenails or simply having a conversation or suturing so the doctor can charge or doing all of it? Why are we so invisible in this society? Because they don't want to know how hard and how complex the work we do is. Sorry, got off track. So for me, experience, and that's why you can see scabies and impetigo. Now, this was from the Coledale, where they're all white. The same issues as I see in every Aboriginal remote community. Now, data analysis, and a lot of them will use the PenCat or the new Cat4 or whatever. A lot of you will have that attached to your best practice or med director. Pull your data. This tells me that I've got bulk of children, and when I broke it down, they all had ENT and respiratory issues. And so, and burn off is a nightmare with kids with asthma. So one of the health workers, is her little target is she's promoting getting all the kids in when burn-off starts to make sure they've all got their asthma meds and an escalation plan. That was off her back, because we knew we were getting a heap in. Look at this one. Up in this area, that blue is malnourishment. 0 to 4, 5 to 9, up to 14 here. All the kids are malnourished, severely malnourished, yellow being normal. And so, you know they're all skinny and scrawny when you come in, but when you start to break it down, run a worming program, tackle things that you can tackle and simply, and then obesity from there on. So your data will drive what you need. Even though you might empirically see this or this, if you pull your data, then it also will drive what you probably need to do in your own practice. This one shows when pulling that diabetes, hypertension and hyperlipidemia in the adult population were the biggies. So might drive you on something that you want to do, but and help. And so, like I said, in some of these communities about feeling now, it might not be raving on about the tablets, it might be a little bit part of it, but we're running cooking classes on low-fat diets, come along. That's a now. Food, things now. Or we're going to get this dietitian in to show you how to make really great snacks for through the day that are, you know, no fat. But it's got to be a now thing, but so it's thinking about what you can do and target like that. So now you've got many ideas and you've got experience and you've got your data, and so now it's figuring out, along with your patients, about what they can live with and what you can take on. And Robbie gets out and interviews his patients and talks to them. He's doing these concepts, whether he followed that theory or he's just darn good at it, he's doing that anyway. And so putting them along. And I wanted to throw this in because health promotion v health education, some people get a bit confused, but it's a combination of both. And this sort of helps to support it. Your education is for the knowledge, attitude, skills, behaviours, indicators and their status. And you also are doing environmental actions. So environmental change, teaching the mums to wash the kids in tea tree soup. So it's not just about educating, but it's actually looking at all the things that sit under it and what you can do within your area. So health promotion is both. It is a combination of both, and you can't separate it. And remember what I said, don't start something that you can't do. Oh, I've got too many patients. Oh, I've got the women's clinic. Like, it's got to be sustainable, or if you're unreliable, then people can't give up their valuable time when you're not reliable or anything else. There's tools out there if you want to look from. This is from Menzies. There's great tools out there on planning and auditing. You need to audit to know if it was successful or not. And the appropriateness of the media, and we've heard some great ones on social media, but for some areas social media is not an option. They've got a different mobile every week, a cheap $20 thing, or they've passed it on, or a different chip, or there's no, because there's just no Telstra out there. Even telly, and you can't watch Netflix. Oh God. Know your own prejudices. So I know I lecture my kids, but I can't do that with patients. So you've got to know all your own prejudices that you feel that they should be just told this, but reflect back on it. There's lots of ways of doing it. There's so many ways you could target things to get your messages out. But make sure your message is clear, because people so often misinterpret what was said to them. They'll hear several words, but they misinterpret what was actually said. So I had a man back in with triglycerides of 7 and a cholesterol of something similar, and he said, but my last test was perfect. I thought I was cured, so I stopped all my tablets. So your message needs to be clear about things. And don't always, I think this is always important that people forget the words, they remember how you made them feel. So some of the old sexual health posters was, it made everybody feel dirty. And so how you target that? Just an ad, an anonymous ad. It's how you make people feel. We have many choices. Like I said, we've got to pick the one that we live with. And especially for, as I said, for Aboriginal people on a lot of the missions, life is circular. It's about the past and now, not future. And so how are you going to dance in that? You're bringing valuable pieces of culture sometimes, and a lot of the elders or the councils will say, I want to use the fact that that we lived a life where there was no cordial, where we're bringing valued pieces of the past to the present to reach people. So it's not always about what are you doing today and the future orientation, but sometimes it's past to now. If one-on-one, don't use paternalistic, blunt or accusatory tones. Oh, it's obvious you haven't had your medications again. That's what I get told all the time. We speak and give messages that we make out that everything we're going to do is turn to gold. Oh, take that lipid tablet, you will never have a heart attack. You've got to be clear that we're not turning everything into gold. We're trying to make a better quality of life, but it's not always gold. And like all of our patients said, God, I'm always afraid coming here to find out what I've done. So they're anticipating that they're afraid and guilty as soon as they walk into a lot of places. And so that's, I think, part of our role, where we make them feel welcome and that they can say anything, and we're non-judgmental. And we try and slip in something that might help them, but doing there. And a lot of patients who look shy and uncertain, a lot of Aboriginal people are absolutely just quiet. And they come out and tell people they trust afterwards, later. So they're not like that. And self-awareness is not a strong point for most people, yet self-deception is an art at which I excel. I will be okay. We all do it. Put your hand up here if everyone is exercising 30 minutes a day, eating an absolutely perfect diet, taking all their tablets and doing everything. We are really good at self-deception, and yet we're so quick to jump on the bandwagon of our patients. So we're really good at self-deception. So I just want to throw this other one in, and I think it ties in with yours, is if you do nothing else, do a health promotion on ourselves. We are not we're the people who can fix people. We can connect with people. If they come into us, we will direct them out to which person they need to see. Can they simply go, because I know my GP doesn't do skin surgery, get them to the skin cancer clinic down the road. People can come in. We don't promote ourselves as the health option. And I think it's something that we need to do, because we sit on health education, we change attitudes and behaviours. So we fit into this. We need to show that the environmental actions that for us promoting ourselves sit with our advocacy and our social support, minimums on what we do. You need to turn health promotion around. If you do nothing else within your own practice, is promote yourself. Put the posters up. Don't want to talk to anyone else? Come and have a yak with me. It stays with me. Just advertise. Talk to me. It stays with me if you don't want it to go further. And so many will do that. And they go, oh, no, I can't, that's shame. Oh, doctor, this one's thinks they've got chlamydia, I'll just give the azithromycin, you're okay, I'll take the urine sample. Yes, we can keep it with us, but we don't promote ourselves as people being a solution for many options. Thank you.